This conference will now be recorded.
Good afternoon. My talk today will be on the emergence of integrative medicine, a brief history, and a look at some paradigms. I will begin by looking at changes in the way that illness itself presents, then examine the need, both economic and human need, for a transformation in healthcare, look at some visions of the new healthcare, and then examine a series of paradigms or models for integrative medicine, looking at the paradigm of integrated care within traditional medical hierarchies, the paradigm of interprofessionalism, which emphasizes communications, the smorgasbord paradigm, the epigenetic paradigm, lifestyle medicine and health coaching paradigm, the functional medicine paradigm, the competencies-based paradigm, and the ecosystems paradigm. Finally, I will return to the question of how can we bring this all together and examine some of the values that we're looking for in integrative medicine. The College of Integrative Medicine has a take-home message for you today. And that message is that we're looking for an approach to healthcare that is holistic, integrative, person-centered, relationship-centered, evidence-based, and oriented to mind, body, and spirit. The Mind, Body, Spirit Integration Seminar will introduce you experientially to a number of mind, body, spirit practices. These practices will be presented in their simplest forms for you to carry out. The academic complexities, the research on mind, body, spirit practices will come later in your academic classes. But here we invite you to remain open, to empty your cup, and allow yourself to experience at the emotional level, the personal, physical, intuitive, and spiritual levels, the impact that these practices can have on you when you take them seriously. The face of illness has changed. Well, 100 years ago, physicians faced the scourge of acute conditions, which often killed quickly. Patients suffered infectious diseases such as malaria or typhoid, and large parts of the population could die out in a short time when an infection spread through a community. People also suffered from bacterial parasites for which there was little effective treatment. And finally, unhealed physical trauma. I know in my own family history that one of my great-great-grandfathers was dragged by a horse down the main street of a small West Michigan community. The accident didn't kill him, but he died several days later of untreated infection. At that time, there was no real treatment for infection, and it was often the infection from a traumatic injury which killed the person. Life expectancy in 1900 was 39 years. We've come a long way from there, and it's not just medical care, it's the impact of public health, immunization, the availability of antibiotic medications, which have reduced the illnesses of the past to the margin in healthcare. Today's Western primary care clinic rarely sees typhoid, cholera, smallpox, or polio. This picture shows you immunization. The next picture shows you the clean water that we take for granted. And this is a young child in a developing world community. The village has just obtained access to water and clean water. The face of illness has changed because of breakthroughs in public health and immunization. Today, a patient is much more likely to come to the primary care clinic, stress-related conditions, diseases which come from adapting to the to our lifestyle, to our environment, which is often stressful and pathogenic. In other words, our environment can cause illness. We suffer often, especially with the process of aging. We see many people suffering with multiple chronic illnesses and conditions. And we have many complex biopsychosocial conditions. There may be an element that is medical, biomedical, but there are also factors in the psychosocial conditions around the person which contribute to this particular episode of the illness. So we need to attend to both the biomedical and the psychosocial. Now, this shift toward chronic illnesses and lifestyle-based illnesses is a global it's a global change. It's not simply happening in Western developed affluent countries. In the past, that was true. Developing nations were most challenged by communicable or infectious diseases. I became involved in the Caribbean because I was involved with a group that was sending medication to support some medical clinics in Jamaica, Haiti, Honduras, and the Dominican Republic. And we began to ask the question, why is there such a need for so much diarrhea medicine and medicine for lung disease? What are the conditions that are causing people to use so much of this medicine? Well, of course, the lack of clean water was causing the diarrhea-related illnesses, which in many cases were killing people, especially children. And the lung diseases had a very simple cause. In Honduras, the families cooked inside, the children hung on their mother's skirts as she cooked, and there was no venting of the fumes from the wood fires and the stoves. So our project, instead of simply sending medicine to treat the conditions, began to develop with the local communities some projects to establish availability of clean water, which would not cause illness, and venting stoves. Volunteers in conjunction with the families built adobe stoves with metal vents that took the fumes out of the home. So that's just one example where typical illnesses in a developing country we expect to be infectious. However, we now see increasingly high levels of health problems that are related to chronic disease and lifestyle. Some of the factors that contribute to these chronic diseases and lifestyle-related diseases are aging populations around the world, rapid urbanization, especially younger people leaving the village, the rural community, moving into the city and adopting Western lifestyle. So we see a globalization of McDonald's and excessive alcohol use and excessive, use of tobacco. Poorer qualities of food, fast foods, increased psychosocial stress, and still limited access to health care. So we see disadvantaged and vulnerable populations in both low and middle income countries are at a greater risk for health problems because of these factors, and it's those lower and middle income populations that have limited access to health care. So the global burden of chronic and lifestyle-based illness impacts most heavily on disadvantaged groups in all countries worldwide. Now I'm going to show you some of the data that tells us we absolutely need a new healthcare, a new approach to healthcare in the United States, and much of this could be true elsewhere. In the United States, we see an escalation of healthcare costs at a rate that we really can't sustain economically. The US spends 16% of its gross national product on healthcare, more than any other country. Projections are that by the year 2035, we will spend 31% of our gross national product on healthcare. In other words, much of the economy is becoming devoted to healthcare. And yet we still have a substantial part of the population which does not have access to regular primary care. Our health statistics are actually falling behind those of other affluent countries in areas such as infant mortality. This is a quotation from Bruce Boissonnault, president of the Niagara Health Quality Coalition. He said, despite spending nearly twice as much, our results compared to other nations are disappointing. This is a graph showing the more affluent countries, those which have between $10,000 and $110,000 annual gross GDP per capita, per person. And the United States is kind of in the middle of the pack for income. But if you look at the actual spending on health, we are substantially higher than any other country and more than double many countries. These are some more detailed figures. Only Switzerland comes anywhere close to spending the amount that we do. But in spite of higher spending, our life expectancy was the lowest comparing us to other high-income countries. Our life expectancy is 78.8 years. In other countries, life expectancy ranges from 80.7 to 83.9 years. Infant mortality rates are highest in the United States, with 5.8 fatalities out of every 1,000 live births. For other countries, the average mortality rate for infants was 3.6 fatalities for every 1,000 live births. That's terrible in a country which is spending more and yet getting less. A report from the National Center for Health Statistics in December 2016 reported the first reduction in any recent decade in U.S. population life expectancy. The figure I just used was from 2015. This was our life expectancy in 2015, and that's a decrease of 0.1 from the year before. Reports in 2017 and 18 based on data through the year 2017. That's the most recent data that's been processed. Our life expectancy is now down to 78.6. So we're actually losing some of our longevity in the United States. Some of the factors are suicides and drug overdoses. Suicide rates were especially higher in men and in rural areas. Now, this is simply a look at deaths from the 10 leading causes of death in 2016 and 17. 2016 is the darker bars, so you can see that we made progress up at the top in heart disease and cancer, but we're losing ground in unintentional injuries. We're losing ground in suicide. We're actually losing ground in stroke and Alzheimer's disease. So there are a number of areas where we're not keeping up. So what should this new healthcare look like? Well, 20 years ago, Harold Koenig made a statement which I think remains true today. Patients want to be seen and treated as a whole person. A whole person is someone whose being has physical, emotional, and spiritual dimensions. Ignoring any of these aspects of humanity leaves the person incomplete and may even interfere with healing. So number one, integrative medicine needs to be holistic, looking at body, mind, and spirit. Integrative medicine needs to be person-centered. Person-centered means that care focuses on the human being's well-being, coping, and resilience over the course of the lifespan. Biomedical approaches too often focus on the current illness, the current lab work. Person-centered integrative medicine should strengthen the patient for a lifetime of better health, moving the human being upwards in John Travis's continuum of health and disease. Now, this is Travis's continuum. At the far left, we see disease. At the far right, we see higher level wellness. And biomedicine tends to focus down at the lower end of the spectrum, treating current symptoms. Integrative approaches focus lifestyle change, acquiring wellness supporting skills, changing dietary choices to bring the person positive health behaviors that will bring them moderate wellness or even higher level wellness. Now, interesting, we can actually work on the upper end of the spectrum, even with people who have a chronic disease. We can't remove their chronic illness. The illness may even be terminal, as in many cancers. But meanwhile, we can work on their emotional health, their spiritual health, and even their general health, in spite of the presence of a chronic condition which may eventually take their life. But meanwhile, we can bring them so that in their day-to-day life, they suffer less and experience some signs of higher wellness. For many years, we spoke about complementary and alternative medicine. Now, complementary medicine suggests a therapy that can combine with conventional care and improve the effectiveness of conventional care. Alternative, on the other hand, implies using a therapy in place of conventional care. For example, many people on the West Coast actually utilize some form of Asian medicine, partly because there are large Asian communities. And in many cases, the Asian medicine takes the place of a biomedicine for that individual or for that family. Today, however, we're shifting to a focus on complementary and integrative medicine, meaning that we bring together the best of conventional care, conventional biomedical care, with complementary care, and many therapies that were formerly thought of as alternative, as something to be used instead of biomedicine, are now being integrated and provided alongside biomedical interventions, so that cancer patients who are receiving conventional cancer care, chemotherapy, or radiation will also receive acupuncture for pain and nausea, or will receive energy therapies for their fatigue, mood, and other accompaniments of cancer. So we put together the best of the complementary therapies along with conventional care. Andrew Weil has been one of the leaders in integrative medicine, and he says that integrative medicine is healing-oriented medicine that takes account of the whole person, body, mind, and spirit, including all aspects of lifestyle. Integrative medicine emphasizes the relationship, the therapeutic relationship, and makes use of all appropriate therapies, conventional and alternative. Another vision of the new medicine is psychoneuroimmunology. It's been around for a while now, and the research gets stronger and stronger over time. We think of people like Candace Pert, Joan Borisenko, and the emphasis is on using science to understand how our mind and behavior can impact on the nervous system, our hormonal system, and on immune processes. So we can show that simply teaching someone relaxation or self-hypnosis skills prior to surgery not only can produce faster recovery, reduced pain during the procedure, but in many cases can reduce the loss of blood and cause faster wound healing. The wound can actually close faster with the influence of some of these mental and behavioral skills. Now, Nick Cummings wrote a book with his daughter in 2000, and he expressed a vision of integrated and integrative healthcare, bringing everything together under one roof. The patient of the future will encounter an integrated system of behavioral and medical care involving a partnership of behavioral practitioners, physicians, and nurses in one house and one system. Now, I've used this image of a remodel job on an old house because unfortunately that's still too often what the patient sees. Things are cobbled together. The holistic practitioner or the psychologist or the nurse or the nutritionist is not talking to the physician. The physician is antagonistic toward complementary therapies. So we see a lack of unification. But fortunately, there is progress happening in our healthcare system, and actually medical systems, hospital and clinic systems are being incentivized to become more integrative. So we will get there to one house and one system. Now I'm going to introduce some paradigms. Now, paradigms are frameworks or models for how we think about care, and they influence what we do about that care. Okay, the first paradigm I'm going to address is the most commonly integrated or the most commonly implemented one today. And in a certain way, one would expect this because it's an extension of the previous paradigm. Um, Healthcare is typically delivered in a medical hierarchy where the physician stands at the top, the physician's assistant, the nurse practitioner, the radiology tech, and so on, all take their order from the physician and his or her extenders, the physician assistant and the nurse practitioner. Now, typically in this model, the physician or the medical care providers will provide a biomedical intervention first, such as medication, and then supplement this with complementary and behavioral interventions. But the basic model is still biomedical, and that may work in many circumstances, but there are some problems. One disadvantage is that for many chronic conditions and functional disorders, there is an early phase when a lifestyle-oriented or complementary intervention delivered very early may reverse the disorder or at least manage the disorder so that it doesn't progress toward chronicity. Now, the example I might use is headache, that if you provide physical therapy or biofeedback or hypnosis very early when there's only an occasional headache, people will rarely progress toward chronic daily headaches. However, if you provide only medication-oriented treatment, there is frequently a progression as medicines lose their efficacy over time. And by the time the person is referred to that complementary therapist, they're often much less treatable. Now, the one other disadvantage of the traditional paradigm is that no one, including the physician, can reliably predict which complementary intervention might dramatically relieve the disorder. So the patient is not given a set of choices, and the supplementary or complementary care only comes later on. Now, and this is a quotation which I found in a journal for the medical student community. Parsa Salehi said, "This hierarchical construct in medicine is the single most important ethical challenge facing medical education today." That's a dramatic statement, but I think it's true. The next paradigm directly challenges the hierarchical model, and it emphasizes interprofessionalism. The image on the screen shows the patient in the center and a variety of different kinds of practitioners in a wheel around the patient, but each of them is interacting with the patient directly. Integrated care can be optimized with interprofessional teams working in a single setting. Now, I'm going to emphasize what we call co-location, operating in the same setting as other healthcare providers. I've experimented with co-location with primary care physicians over the last actually 35 years, and it dramatically improved cooperation between the different providers, but it also dramatically improved the patient's cooperation with the complementary therapists, the behavioral therapists, because we were all in one setting and there was credibility for all providers in those settings. Diverse professionals work in these settings on a collaborative basis in a single pediatric practice, family practice, or even in specialty medicine settings. I've worked in multidisciplinary pain medicine centers where we worked on a collaborative basis and we chatted about the patient and current treatment progress over our snack or our lunch, and we created a much better unification of our treatments for the patient's benefit. The primary care home, this is the new name for the primary care setting, and specialty care settings can integrate the interventions of physicians, nurses, psychologists, health coaches, and a variety of other health professionals, including the acupuncturist, the massage therapist, and the nutritionist. The interprofessional model challenges all healthcare providers to communicate better with one another and better with the patient. Now, at this time, corporate medicine is pressuring providers, especially physicians, nurses, and physicians' assistants, to reduce the amount of time spent with the patient, reducing the encounter to 7 minutes or 11 minutes. There are a number of models. Interprofessionalism demands time for communication among professionals and with the patient. So there are some tensions between the bean counters who want to get more patients into the physician's day and the interprofessional ideal, which requires communication. One other problem is that the evidence base, the research base for many complementary and allied health interventions is relatively weak. We don't have the huge studies that we have on pharmaceuticals. So some medical personnel are quick to doubt the clinical effectiveness or efficacy of complementary therapies. But I certainly see a move, especially with younger healthcare providers, to show more acceptance for complementary therapies. Now, there's another paradigm which we can call the smorgasbord paradigm. In effect, a number of integrative medicine programs operate on this smorgasbord principle. Patients are offered a variety of mainstream and complementary treatments, and patients select the treatments that suit their preferences. Since much of the CAM delivery system is market-driven and outside mainstream healthcare without good insurance compensation, patient preference then becomes the primary factor driving treatment selection. If I'm going to pay for my acupuncture or my nutrition or my massage therapy, then I'm going to make the choice as to what I choose and what I don't pay for. However, as we begin to integrate some of the complementary therapies into integrative care settings, and especially when we're able to integrate payment for those therapies, you will have more professionals involved in helping the patient make choices. I've been to health fairs, and it seems like patients are prone to make a number of choices which are not really based on any kind of evidence for the effectiveness of the treatment. Crystals and magnets and a variety of things which may be somewhat helpful, but which we don't have very solid research for, are very popular, and yet some of the things like biofeedback and hypnosis are have a very strong evidence base. Research shows their effectiveness, and yet they're less widely used. This is a diagram from NCAM, the National Center for Complementary and Alternative Medicine. It's based on somewhat dated data, about 10 years old, but it just shows you the most popular CAM therapies are natural products, things you put in your mouth, deep breathing, meditation, chiropractic and osteopathic, massage, yoga, diet-based therapies. As I mentioned, some of the strongest research is in areas like biofeedback and hypnosis, and those aren't even on the chart. They're not among the top 10. Epigenetics. Okay, epigenetics is another paradigm for integrative medicine. Epigenetics looks at how does the DNA code that I carry influence my health. There are a number of variables which influence what we call the translational process, which determine the potential traits that I have in my genetic code, how many of them actually get expressed. So for example, 10 members of a family may carry approximately equal loading in their DNA for depression, and yet their nutrition, their lifestyle, the amount of stress in their life, everything that happens during the organism's life cycle will modify gene expression. So only some of those family members will get the depression which the family's DNA is capable of producing. The things that happen in our life can benefit us, causing less of the illnesses we're capable of to be expressed, or the things that happen in our life, including early trauma, can erode our health and cause more of the illnesses that we carry in our genetic code to be expressed. Now, interestingly, animal research shows that epigenetic effects can carry over in some cases for 5 generations. So if you give an animal optimal life conditions, it will positively impact health of the next 5 generations of that animal. On the other hand, if you treat an animal with really abusive, isolating conditions, food deprivation, things like that, you will see 5 generations of worse health coming from those conditions. One example of this is the Dutch famine, the Netherlands, during World War II. The Nazis were occupying the Netherlands, and in 1944, they began to take all of the crops that were being produced on Dutch farms and exporting them to the German armies wherever they were fighting and to the German population in the German homeland, so that the Dutch were starving. And these many months of malnutrition produced an increased vulnerability to diabetes, obesity, heart disease, and schizophrenia in children that were born to women pregnant during the famine. So 3 and 4 decades later, the health of those children was affected epigenetically by the poor conditions for the women during the pregnancy in 1944. Bruce McEwen, who is a leader in stress research, has published an interesting article arguing that epigenetics should be our approach or our paradigm for integrative medicine. He says that our focus in integrative medicine should be on recognizing and addressing all of the factors which worsen gene translation and positively increasing factors which positively impact gene translation. Now, I'll give you some of the things which he emphasizes, and they're things we usually don't think of in primary care, but he points out that early life experiences shape the trajectory of health and disease for our entire life cycle. If you look at early intervention to deal with adverse childhood experiences such as abuse, neglect, and poverty, we can actually buffer the effects of that early abuse, that early neglect, that early poverty. If we don't, the patient's likelihood of developing chronic illness is much, much higher because of those early adverse experiences. Trauma leaves a tremendous vulnerability to disease in the person. So we need to intervene early in the child's life in order to eliminate some of the adverse effects of those early traumas. We also need to pay attention to what he calls the lived experiences of the person. Now, this is an expression you'll hear a lot at Saybrook. In other words, it's not only what happens, but it's how does the person herself or himself experience what happens, and how does the person's experiences enhance their response to healthcare or inhibit their response to healthcare. 4 people may suffer similar magnitudes of stress in their life, and yet the person who's able to find some sense of meaningful recovery, to find some sense that I can do this, I can handle this situation, I can master the challenges that are facing me, will deal better with the stress and trauma, and will experience better physical, medical health and emotional health for the rest of their life. McEwen emphasizes stress, what he calls allostatic load and allostatic overload. This is the cumulative effects of stress interacting with our biomedical disorders, so that I may have a vulnerability to major depression, for example, but I'm more likely to have an episode of depression and need treatment at a time when my situational stress has overwhelmed my coping abilities. McEwen also emphasizes what we call neuroplasticity. The brain can regenerate neurons with exercise and positive nutrition, but will deteriorate, shrinking dendrites in the nervous system under stress. So our brain is capable of responding epigenetically, responding to restore itself or to deteriorate depending on my life circumstances. So again, McEwen emphasizes physical exercise, finding meaning in life, behavioral interventions, mindfulness training, all of which can enhance long-term health. Another paradigm, again, not entirely separate, but a different emphasis. We find today a growing interest in lifestyle medicine and health coaching. Now, I put the two together because lifestyle medicine is a branch of evidence-based medicine in which we look at lifestyle changes, which can be used to prevent, treat, and reverse the progression of chronic disease. Some of those lifestyle factors are nutrition, physical activity, stress management, social supports, and environmental exposure. And I mention health coaching here because health coaching is one very effective approach. If you want to change lifestyle, health coaching can help you do it. Now, we've had research for several decades, and we know that 9 lifestyle-related factors and lifestyle-induced dysfunctions can account for 90% of cardiovascular disease. If you look at smoking, excess alcohol use, physical inactivity, poor diet, stress, high blood pressure, and abnormal blood lipids, that is cholesterol, that accounts for 90% of heart disease. The evidence is clear and consistent. Better health will come from correcting these factors. But in spite of knowing that, and physicians telling patients, you've got to quit smoking, you've got to lose weight, you've got to get more exercise, we haven't shown the patient how to make these changes. So lifestyle medicine requires that we actually help people develop ways to change their everyday behaviors. One of the pioneers in lifestyle medicine is a man named Dean Ornish. He conducted research showing that a program of whole foods, vegetarian diet, stopping smoking, increasing physical exercise, teaching stress management, learning yoga, and practicing meditation produces measurable and clinically significant changes in patients with heart disease, cardiovascular illness. And his research was strong enough that Medicare began to compensate patients for participating in the very expensive inpatient Ornish residential programs. Now today, Ornish has moved to a kind of a community-based treatment where people come in for several hours but do not spend time in a residential setting. But he's still getting very effective change. And here's some data about the effects of his program. Patients with cardiovascular illness were able to achieve a reduction in triglycerides, total cholesterol, blood pressure, and increases in myocardial perfusion, meaning there's more circulation of blood. Many patients in his lifestyle medicine studies initially had coronary artery blockages through plaque formation in the artery. And with his program, the arteries opened up and the plaque was reduced, so the blood flow was much greater. The diagram at the top shows a normal artery and an atherosclerotic artery, an artery with a lot of plaque buildup, so there's a narrowing of the artery and much less blood flow. And people in the Ornish program actually removed much of the plaque in their arteries by their lifestyle and nutritional changes. In addition, their mental health got better. Cardiac patients with depressive illness showed improvements in mood in another study, patients in the Ornish program. So here's a statement from David Katz, one of the young leaders in the lifestyle medicine movement. And he describes how we live our lives in America. We let this happen every day. We aid it, we abet it every day. All the while, we devise new drugs and devices, new stents and statins, and we learn CPR to contend with diabetes that doesn't need to happen 90% of the time or more, heart disease that doesn't need to happen fully 80% of the time or more. We seem to accept that it's a normal midlife rite of passage. Will you have an angioplasty or will you have a coronary artery bypass surgery? Take a number, have a nice procedure. You can wait in the fast food restaurant. Next. Now that's the image of where we are today, and the image of lifestyle medicine is making changes in lifestyle to change that. As I mentioned, health coaching is one approach with a lot of evidence base showing that we can aid patients to modify their lifestyle, reduce health risk behaviors, and increase behaviors that enhance wellness. Health coaching optimizes the human capacity to make changes in lifestyle. We facilitate greater autonomy, greater personal competence or mastery of skills, and people's relatedness or connectedness with others. The coach builds a relationship with the patient, invites the patient to have with the coach an alliance for health. We will work on this problem together. The coach uses motivational interviewing to mobilize the patient's own motivation. Self-determination theory strongly influences coaching, and this theory holds that the more autonomous a behavior is, the more your personal commitment will be to that behavior. So I'm not just complying with the physician's orders to quit smoking. Rather, my coach and I have decided I'm ready to set the goal that I'm going to stop smoking in the new year of 2020, or I'm going to increase my activity outside the home by walking around the block or walking to a nearby park twice a day, because that's what I feel ready to do. And when I've set the goal with the encouragement of the coach, I'm more likely to follow through. Functional medicine is another paradigm for integrative medicine. Functional medicine brings together the healing powers of nutrition with laboratory assessment to identify specific deficits in the body that can be addressed nutritionally. Now, this is important because I think many people think that we're going to discover the formula that's going to be right for everyone, so that everybody's going to add walnuts and blueberries to their diet and avoid cancer, whereas in fact our bodies are much more individualized, and our nutritional needs are much more individualized. Yes, it's true, certain things tend to be healthy for us, and walnuts and blueberries are probably better for most people than what we currently put in our mouths. But if I can use lab testing to recognize food sensitivities, gluten sensitivities, dairy sensitivities, nutritional deficits, mineral deficits, my interventions are going to be much more individualized and effective. Now, two areas in nutrition that are getting a lot of attention right now are nutrigenomics and nutrigenetics. So just like the epigenetic approach I was describing a few minutes ago, nutrition is paying more attention to our DNA. And these are two different aspects of the changes that are happening in nutrition because of attention to DNA. Nutrigenomics means I look at how can nutrients modify my expression, my regulation of gene expression. So we have genes that are diet regulated, and they play a role in the onset of specific disease and in the progression of these diseases. Research shows that nutrigenomics has potential for preventing, mitigating, or treating chronic illness and certain cancers through strategic dietary change. So it isn't just making any changes, certain specific changes can have an impact on the onset of cancer or the progression of cancer. Nutrigenetics, on the other hand, studies how genetic variation influences the interaction between nutrition and disease. So this tells us which, because of my genetic makeup, because of the DNA that I have, I can make better choices of what kind of nutritional changes to undertake. So we can have a much more precision-oriented medicine based on understanding my nutritional needs, my health status, and my genotype. And I'll give you one fairly simple example. There's a sports Institute in Cologne, which found that health counseling informed by nutrigenetic analysis was more effective than conventional dietary counseling for weight management. Because, of course, they were showing that because of certain genetic variations, the dietary programs they would develop for people would be different. Another example was a large-scale study. And participants in this study, they identified a number of them who had a specific genetic variation at a location on the DNA in the MT1F3 region. And individuals who had this variation showed greater weight loss from intensive lifestyle interventions than those without the genetic variant. So what we need to do here is design the treatment, the nutritional change, according to the genetic makeup. Now, like many things that we study today in psychophysiology and integrative medicine, the pathways here are reciprocal. In other words, genetic markers predict the response to treatment interventions, but treatment interventions can also have an effect, can blunt the effect of genetic markers. And here's a couple of examples. In one research study called the Pounds Lost Investigation, individuals who had the obesity risk allele at a particular genetic location showed greater weight loss on a high protein diet. Well, if we find that, then certainly we're going to look at the DNA and we'll identify people who should have the high protein diet because they're likely to respond with weight loss. In another study, participants in the study who had a genetic marker at TCF7L2 with a specific marker there showed more frequent progression to diabetes. However, if you had this marker, but you also did a specific lifestyle intervention, there was less frequency of developing diabetes. So here again, lifestyle can impact on genetic expression, and genetic expression impacts which lifestyle or which nutritional change will be best for us. I'm going to shift and look at another competency, another paradigm, and this is a competency-based paradigm. Now, today in higher education, especially in the health sciences, we see an emphasis on competency-based approaches. And this is parallel to the evidence-based approach in clinical practice. So if I'm going to become a nurse, there are a number of competencies that I have to master. If I'm going to become a nutritionist, there are a number of competencies I need to master. And in integrative medicine, we can recognize there are a number of competencies that make for better integration of treatments in medical and behavioral services in one setting. Now, much of the research on competencies so far has to do with putting behavioral health, social workers, psychologists into the same setting as healthcare personnel, so bringing together behavioral change with biomedical approaches. And so when I describe to you some of the core competencies, these have been worked out so far, bringing together medical people with the mental health workers. And here's a quotation: competence as a licensed behavioral health provider working in primary care refers to the knowledge, skills, and attitudes and their interconnectedness that allow an individual to perform the tasks and roles in that setting. So it's not just what nursing skill do you have or what social work skill do you have, but do you have the communication skills, the interprofessional skills, we might say, referring back to another paradigm, to interact effectively with other members of the treatment team. There have been several consensus conferences in this area where experts come together and reach an agreement on what competencies we should emphasize in education. So the Colorado Consensus Conference, held in Colorado, obviously, identified 8 competencies that make for more effective integrative care. I'm not going to read them all. You will have a copy of this video, so you should be able to come back and read them. But identify and assess behavioral health needs as part of a primary care team, help observe and improve care team function and relationships, communicate effectively with other providers, staff, and patients, provide culturally responsive, whole person and family-oriented care. So another area that we won't spend time on today, but you will at Saybrook. We have to be culturally appropriate. If I'm treating people in an Asian community, I'm going to have to adapt the treatment and my relationship with the patient and with the family to that culture. If I'm going to work on a Native American reservation, a tribal area, I have to become familiar with the mores, the lifestyles, and the values of that specific Native American community. And the treatment will be more effective if I do this. So these are competencies emphasized for integrative medicine. There was another consensus conference in Annapolis, Maryland, and very similar competencies were developed by a different group of professionals. And they said that for integrated care, for effective integrative medicine, we need interpersonal communication, collaboration and teamwork, cultural competence, systems-oriented practice, health informatics, the use of information science to inform decision making. So some very important values reflected in competencies that have to go into education. Another paradigm, and this will be the last one I present, and that is to recognize that we live in an ecosystem, and the ecosystem can either be pathogenic or supportive of health. I'll give you an example. I attended a conference in Austria on forest medicine. Also, some of the nature therapies are known to provide some benefit to people who are deprived of nature, living in a concrete jungle, so to speak, an urban environment with very little green. One of the interventions in forest medicine is called forest bathing, immersing the person for several hours in arboreal forested environment. One of the stimuli for global lifestyle-based illness is rapid urbanization and estrangement from nature. And forest medicine emerged in Japan, but it's growing worldwide. Immersion in nature is treated as a form of therapy, and we might say that there's nothing new in this movement. Ralph Waldo Emerson, in an essay on nature, wrote, "In the woods, I feel that nothing can befall me which nature cannot repair." So he felt that there was a healing quality to spending time in nature. Miyazaki, a Japanese researcher, published a review of the Japanese research on forest medicine and reported decreases in cortisol levels, decrease in sympathetic nervous activation, decrease in heart rate, increases in parasympathetic activation, meaning more relaxation, and an increase in immune function when people are immersed in a forest setting. Western research is now carrying out similar studies, trying to test with very rigorous research design. And clearly, exposure to nature and green environments is beneficial for human beings. And one study even said even houseplants can make a difference, reducing psychological and physiological stress levels. So we need to pay attention to the environment that we spend our life in. Now, bringing it all together, paradigm, go pick a paradigm. Well, which paradigm is right? I don't think that any one of these paradigms is right, is the paradigm that we should turn to. Rather, I think we should be aware of all of them. Clearly, they overlap. If you pursue lifestyle medicine, you will be creating the conditions for better epigenesis, for better translation of the positive aspects of our DNA code and less of the negative aspects of our DNA code. So these paradigms actually, many of them accomplish some of the same things and in parallel compatible ways. But there are some values that I think we can identify across the paradigms. Values which infuse integrative care, integrative health care. First of all, we emphasize mind, body, spirit because psychosocial and spiritual crises contribute to illness, and psychosocial and spiritual change in a positive direction can contribute to wellness. We have to recognize that stress governs the onset and the worsening of much of today's illness. We want to focus on lifestyle changes, changes in attitudes, and acquiring self-care skills. And you will be exposed to self-care skills in your Mind, Body, Spirit integration seminar as a new Saybrook student. We're dedicated to pursuing higher level wellness, not just treating illness. We're attuned to quality of life when illnesses cannot be cured. We focus on the person and not the disease. We emphasize interventions that bring out the healing powers of the organism. And rather than trying to just crush the illness, we try to draw on the person's capacity for healing. We look for and encourage an active role of the patient in the healing process, self-managing their illness, making decisions, informed decisions about their own health care. We strongly emphasize a personal supportive relationship between the healer and the patient. Research on empathy shows that even adding a few minutes to the treatment encounter actually is more effective than the particular choice you make of which medicine to give the person. It's a very strong factor when you increase the empathy, the empathic understanding between the patient and the healer. We distrust invasive treatments that crush the disease but harm the patient. There may be a place when they're necessary with some cancers, but whenever possible, we rely on treatments that are more gentle, that draw on the healing powers of the person rather than trying to crush the disease. We pay attention to the human being's history, including adverse early childhood experiences, because these experiences have a tremendous effect on who gets sick, who experiences disability after traumatic experiences, and who suffers worst consequences from illnesses. We focus on the patient's lived experience, the meaning that the client is pursuing in their lives. We look at epigenetics, lifestyle medicine, functional medicine. All of them come together looking at the long-term health impact of every element in our lifestyle. And finally, we're looking for healthier environments. What can we do to increase the patient's exposure to healthier environments and decrease their exposure to what we call pathogenic or disease-causing environments? Thank you for your attention, and that concludes my lecture. I hope that this gives you a framework to begin your Mind, Body, Spirit integration seminar. Take care and goodbye.